This topic is traction. Traction is an intervention used to help realign long bones following a complete fracture, meaning the long bone has separated into distinct pieces. When a long bone breaks, such as the femur, tibia, or humerus, pieces of the bone can slip past one another, and the muscles, ligaments, and tendons that surround that bone can contract. Ultimately, this can lead to a shortening of the limb, which contributes to misalignment of the bone. Traction applies the use of a bidirectional pulling force, meaning to pull in two separate directions, to help realign and immobilize the bone. One of the pulling forces is a set of weights that actually applies the traction, while the other is either the client's body weight or a separate set of weights which applies countertraction. We'll be able to see the relationship between traction and countertraction in later slides. The two main types of traction are skin and skeletal traction. Skin, or buck traction, is a type of traction that applies a pulling force directly to the skin through the use of boots, splints, and tape. There are some limitations when it comes to using skin traction. It is considered a temporary measure and is usually the first type of traction applied following a long bone fracture. This type of traction can only be used for 48 to 72 hours before a client may need surgery or the use of long-term skeletal traction. Additionally, only small weights can be used to apply traction, as heavier weights can cause nerve and tissue damage when it comes to applying pressure to the skin. So a weight of 5 to 10 pounds or 2.3 to 4.5 kilograms can be used for older children and adults. And a weight of 2 to 3 pounds or 1 kilogram can be used for infants. Complications of skin traction include skin breakdown and detachment of the traction device. Therefore, the nurse should monitor the client's skin frequently and check to ensure that the traction is being applied appropriately. Let's talk a little bit more about weights and their purpose during traction. Remember, when a long bone fractures, the bone pieces can slip past one another and the muscles, bones, and ligaments can contract, shortening the limb. This ultimately contributes to bone misalignment. Therefore, a counteracting pulling force is needed to help realign the bone and immobilize it. To accomplish this with skin traction, a weight is attached to the client's boot or splint and is continuously suspended in the air, freely off the edge of the bed. It's important to note that if the weights are not hanging freely and instead resting on the ground, that gravity is not acting on the weights and applying forceful traction. This can result in complications. The client is also laid in a supine position in the bed with the foot of the bed elevated at a 15-degree angle, and the limb should remain in a straight and neutral position for realignment. Skeletal traction uses some of the same principles as skin traction. However, the force is applied directly to the bone instead of to the skin. It can be used for up to 4 months, which is a significantly longer period of time, and a larger amount of weight can be used, anywhere from 5 to 45 pounds or 2.3 to 20.4 kilograms. To apply skeletal traction, the healthcare provider will surgically insert screws, pins, and wires directly into the pieces of fractured bone. These surgically inserted screws or pins are left exposed to the outside of the body. That way, they can be attached to a pulley system with free-hanging weights. When using skeletal traction, countertraction is necessary in order to maintain traction balance, as opposed to skin traction, in which the client's body weight is able to apply sufficient counterforce. Let's look at the image on the right side of the screen to help us better visualize the difference between traction and countertraction. We can see that one set of weights is hung at the end of the bed, pulling the bone in one direction, applying traction. And weights hanging freely at the head of the bed are pulling the bone in the opposite direction, applying countertraction. Again, this helps to realign the bone and immobilize the fracture. When a client is in skeletal traction, they should be laying supine and perpendicular to the ends of the bed. The affected extremities should be aligned in the proper position in relation to the body. The head of the bed should be flat or in a semi-Fowler position. However, we want to make sure that we don't increase the head of the bed beyond a 20 to 30 degree angle. A trapeze should be made available for upper body movement and repositioning. Essentially, the client can use both of their arms to pull up on the trapeze and independently reposition their body. This helps the client maintain their independence and helps prevent skin breakdown. Keep in mind that the client should maintain their affected limb in its appropriate position. And the weights at the foot and head of the bed should be hanging freely. A different type of traction that can be applied is known as static traction. With static traction, a halo external fixation device is applied to the body to help stabilize a cervical or high thoracic fracture. This type of traction can only be used if there is no damage to the ligaments surrounding the spine or damage to the spinal cord itself. To stabilize the spine, a halo ring is applied around the head and secured in place with pins that are inserted directly into the skull. Then, the halo ring is attached to a large vest when the spine is in a stable position. While in place, a small pillow under the head will help reduce pressure on the device itself. The nurse should make sure that the correct sized wrench to adjust the vest is made readily available, as the vest itself will have to be removed if the client needs cardiopulmonary resuscitation. The vest should be kept clean and dry to prevent skin breakdown, and the pin site should be cleaned daily to prevent infection. Let's revisit long bone skeletal traction and discuss complications. For long bone skeletal traction, it is important to maintain the limb in proper alignment to prevent bone malunion, which can lead to muscle spasms and increased pain. To prevent these complications, the nurse should ensure that the client's limb is in proper anatomical position, that the weights are hanging freely off the end of the bed, and that the proper amount of weight is being utilized. Additional complications of skeletal traction include infection at the pin site. Remember, the pins are exposed to the outside of the body and are connected directly to the bone. If the pins are not cleaned daily and as needed, the client is at an increased risk for infection as well as developing osteomyelitis. The affected extremity undergoing skeletal traction is at an increased risk for developing muscle weakness and atrophy, as well as skin breakdown. And overall, prolonged immobilization can lead to the development of atelectasis, constipation, and deep vein thrombosis, or DVT. To reiterate, if a client has skeletal traction applied, the nurse should be checking the pin sites frequently to assess for signs of infection. This includes redness, swelling, purulent drainage, and an increase in pain. And if the soft tissue does become infected, this increases the risk of osteomyelitis or the development of life-threatening sepsis. Whether the client is undergoing skin or skeletal traction, the nurse should frequently assess capillary refill and pulses to make sure that the extremity is getting appropriate blood flow. An incentive spirometer should be used to help prevent atelectasis. We should provide a high-fiber diet, stool softeners, and fluids to help prevent constipation. Prophylactic anticoagulants should be administered to help prevent DVT. We should monitor the client's skin frequently and reposition them in order to prevent pressure injuries. And promote urination with the use of urinals, bedpans, and, if necessary, intermittent catheterization in order to reduce the risk of urinary tract infection from indwelling urinary catheters.